quality of life, I guess, helps contextualize survival. So living longer, of course, is important, but how patients live matters just as much, is what I think. So if, say, two treatments have similar survival, but one preserves functions and reduces symptoms or minimizes treatment burden, that matters.
Hello everyone, my name is Kevin Bambury and I welcome you to another episode of Oncology Spotlight. Thank you for tuning in. Our guest for this episode is Dr. Shreyas Kalantri, who is a Chief Fellow of Hematology and Oncology at the University of Louisville Health Brown Cancer Center in Kentucky. Thank you for joining us, Dr. Shreyas.
Hi, Kevin, thank you for having me.
So just to kick things off, could you briefly introduce yourself and share a bit about your background?
Yeah, sure. So I'm Shreyas Kalantri. I'm currently the Chief Fellow in Hematology and Oncology at the University of Louisville. I grew up in India. I went for my medical school in Mumbai and eventually made my way to the US for residency and fellowship. Clinically, my focus is in solid tumors, and academically, a lot of my work has been around immunotherapy outcomes, quality of life in clinical trials, and long-term, I hope to be involved in clinical trials and continue to keep on doing the research work that I'm doing. And outside of, I guess, day-to-day clinical work, I'm involved with training and early career oncology initiatives. I co-lead the HemOnc Fellows Network platform, and I also serve as a member on the ASCO's TCAD group. All of this experience, I would say, have been incredibly rewarding. Yeah.
Wow. Oh, can you tell us a little bit about, your path from medicine in India to the US?
Yeah, sure. So during my final year of my medical school, I came to the US as a visiting student. So I did rotations at places like Weill Cornell and in Florida. And those experiences opened my eyes to the infrastructure in this country, the research infrastructure, and just in general, I would say. And also led me to realize the time that you can spend with patients here was quite you can actually give some more time to the patients here. And I remember thinking, this is the kind of environment I want to train in. So I took the USMLEs, did well, and matched into residency in Baltimore. This was in 2020. And as you remember, right at the start of the COVID-19 pandemic, not the easiest time to say transition to a different country internationally across continents. The first few months, I would say, were challenging and formative. Most of my panel was COVID-19 patients, and but really it was a rewarding experience and made me understand how we as a team can work together. And then during residency, especially when I did my HemOnc clinics, it became clear that this was a field that I wanted to do to be in the for my rest of my life. And that's how I ended up in Louisville for my fellowship. And now here I am doing exactly what I want to do. So it's been a great experience.
Brilliant. And can you tell us why hematology and oncology, what kind of shaped your interest in that space?
Yeah, so my very first exposure to oncology was actually back in India. So during my internship, which is the final year of training in medical school in India, I was doing a rotation at Nair Hospital, which is my medical school. It is one of the top schools in the country. And I was working with the medical oncologist there. And that was the very first time I realized, I guess, two things. How much is the need there is for oncologists globally, and how meaningful the patient relationships can be. Later on, I did some away rotations in the US at Boston University and even at the University of Louisville. And I just fell in love with the field to some degree. And I remember sitting down with a fellow as a medical student and going over the recent immunotherapy trials and feeling like I was watching the field change in real time. At that time, I think it was 2019, and there was just recent clinical trials with immunotherapy with Pacific and Keynote 189 in lung cancer that had came out a year or two prior. And I didn't know much about immunotherapy back then as a medical student, and it really just opened my mind to new things. And Then during residency, I actually tried to perceive every HemOnc rotation possible. So my residency program has an academic partnership with Hopkins. So we kind of did solid tumor service at Hopkins. Um, and then I also did away rotations at University of Maryland and GW. And all of those rotations kind of pushed me towards oncology. And during that time, I figured that this was such a rapidly growing field. And as someone who's very growth oriented and felt like being in a fast moving specialty like this is just where I wanted to be. And what really sealed it for me, though, was, I guess, the longitudinal patient relationship that you have. I think you are helping these patients through a really difficult time, and just to be there for them and walk with them really just checked all the boxes. So that's how I ended up in HemOnc.
Yeah, that makes a lot of sense. That makes a lot of sense. And I know you said you're doing your fellowship now. What year fellow are you?
I am in my final year, third year of my fellowship. I also serve as a chief fellow at my program.
Okay, very good. And is each year is the fellowship different, or how does it progress?
So it really depends on the fellowship program. My particular program is structured in a way that a lot of our inpatient time is done in the beginning half of the fellowship, the first half of the fellowship, and more of the outpatient clinic is in the second half. So the continuity clinic keeps going throughout the 3 years, but at the same time, your outpatient workload increases as you progress through your fellowship. And since your inpatient rotation goes down as you are in your third or second year, for instance, in my third year, I don't do any inpatient rotations at all. But at the same time, most of my time outside of the outpatient clinic is towards research. So that gives me a good balance to do clinical workload and do my research projects.
Yeah, excellent. And what pushed you? What experiences in your past pushed you towards academic oncology more so than the community setting?
I think oncology naturally pulls you towards academia to some extent because it's so research driven. I guess as like we met at different meetings ourselves, and every major meeting has this new trials and new data and new drugs which are coming out. You see all these people presenting different trial information, and that really kind of gives you the motivation to work towards it a little bit. And when you're in your fellowship, I early on started doing a lot of different projects, some clinical, some database, and different research projects. It really kind of helped me understand the work that I was doing on the clinical side of things. Like when the more projects I was doing, the easier it was for me to interpret the clinical trial data that I was relaying the information to the patients. So once you kind of understand something, you enjoy it more, and then you want to do it more of it. So that's what happened to me, I feel. I think now that I've taken this part, I want to see how the future holds. Yeah.
No, that makes a lot of sense. And can you tell us a little bit about the HemOnc Fellow Network? What inspired you to join that and become the leader?
Yeah. So I think it's just an idea of giving back. I benefited so much from different mentors and from the oncology community as a whole. And so just being able to contribute back, especially to the trainees, it just felt very natural. HemOnc Fellow Network, I was reached out by one of my colleagues to co-lead it, and I readily said I was more than happy to work towards it. And this has grown into such a wonderful platform on X with more than 7,000 followers. And we host monthly webinars on mentorship, let's say match, results in jobs, and transitioning to practice. And these are the things like residents, fellows, and early career oncologists really need, but don't always have access to. And somehow the way that I ended up in HemOnc Fellows Network was through the Trainee Advisory Group members. So it is a different but a really meaningful experience itself. So Trainee Advisory Group a little bit it's basically a voice to ASCO from trainees and early career oncologists. We get to raise issues that matters to trainees globally. And we also plan some of the educational sessions and panels to the main ASCO meeting. And as someone who always wanted to advocate for trainees, uh, through residency, through different communities that I was a part of, that just felt like right opportunities. And I'm grateful for ASCO to be able to give me these opportunities, I think.
Yeah. So you guys kind of gather feedback from trainees and fellows around the world and, feed that back to ASCO then.
Yeah, and to some extent, yes.
Yeah. Excellent. That's great. That's brilliant. And the HemOnc Fellows is like it's kind of like a meeting that you guys do every.
So HemOnc Fellows Network, it's its own entity with its own space. It's a network for fellows by fellows. So yeah, it gives. So we are a couple of fellows, and it was started by a few fellows who are now attendings, and they passed it on to us. And I will eventually pass it on to the incoming fellows as I pursue my future career. So basically, we try to arrange webinars in different space on X, and that helps, and that we try to cover different topics which are more directed towards trainees and early career oncologists, and what you want to learn about, from mentorship to match and other avenues. Yeah.
Excellent. Sounds like a really great initiative. And then how do these initiatives impact the future of oncology for trainees and young oncologists in low resource areas?
I think in today's world, the social media has pretty much removed the barrier that used to exist. So any webinar or any space that we hold on X is accessible to, I guess, someone in India or Africa or Middle East, anywhere in the world. So this kind of democratization of information didn't really exist before. So that really, and it's free to log in, and anybody can just join the space and learn a little bit more as they are being conducted. And similarly, in TCAG, we have like members from multiple countries. For instance, at the very recent meeting that we had in, I guess, last week, actually, the very first topic that was brought up was about global oncology and how we can collaborate not just across states, but across continents. And when we look at it today, honestly, clinical trials have become stronger when we have global representation. That makes results more, I guess, generalizable. So I really believe that these initiatives help level the playing field in a small but meaningful way. It's a small initiative, but at the same time, we are doing what we can for oncology as a whole.
Yeah, of course. And these webinars are open on X for anyone to join.
Yes.
Cool. We'll make sure to link in the show notes, so if anyone's listening, they can join in and be part of the webinars. Can you tell us about some of the papers you've authored or co-authored in oncology, and maybe some of their takeaways, some of the key takeaways there?
Yeah, I can. So let me start with one of the very first projects I did in my fellowship. It was a lung cancer phase 3 quality of life systematic review. So basically, in the very first few clinics that I was on, I was with my attending, and we were discussing different clinical trials and based on the patients that we were seeing. And one of the things that I noted during that discussion was, and when we were looking at different trials, was quality of life seemed to be a little underrepresented. There was a lot of focus on overall survival, which is, of course, important. We want to improve survival for these patients. But at the same time, the data related to quality of life wasn't as evident. So what I decided to do was to do a systematic review where I looked at phase 3 lung cancer clinical trials from 2019 to 2023 to assess how often was quality of life being included. And at the time, I noted around 32% of the clinical trials had quality of life as an endpoint, which is much lower than what I was hoping for. Even amongst lung cancer, I think metastatic non-small cell lung cancer had, where quality of life I feel is incredibly important, only about 1/3 of the cases had incorporation of quality of life as an endpoint. Small cell was even worse. It was only 20% or 19% of the clinical trials which has quality of life. And as we know, it is a very aggressive biology, and every day matters. We want to raise their survival, of course, but at the same time, if every day matters, the quality of that day matters too, I feel. And So I think that is what led me to do that study. And this is, I feel, not a conceptual issue. This is has been recommended by FDA and ASCO and other guidelines. And despite that, there's a huge gap that remains. So that's one study.
Mm.
And another study that I did was more recently, that was published at JCOP, which is a JCO's Oncology Practice Journal. It was basically a study to assess the differences in survival before and after the immunotherapy and how the disparities have still persisted. So we did that in melanoma. We also did that in lung cancer, which is still under review. But the one melanoma one was published. So basically what we saw was uh, immunotherapy, of course, as we know, has improved the survival tremendously in melanoma, with pretty much doubled in stage 4 and all of that. But the disparities have pretty much persisted. So even in the immunotherapy era, say, insurance status was a huge predictor of immunotherapy. People with no insurance did significantly worse as compared to patients with private insurance. Black patients still had lowest survival. Patients at non-academic centers did worse. Lower income and lower education group had worse outcomes. And sex and age, as always, there were some differences that persisted. So while immunotherapy has, I guess, changed the landscape, which it has, but it didn't automatically fix the inequities in access and outcomes that are still there.
Yeah. And why do you think they exist? Or do you have, do you
Uh,
know?
I think the key barriers, I think, to access is basically, I think it's a multi-pronged. I think multiple issues are playing a role at the same time. I would start with, I guess, financial toxicity. Immunotherapy is expensive and insurance is not cheap. And even with insurance, out of pocket cost can be a real barrier. Um, and as we saw, like patients in rural areas and have issues with access to infusion centers, or there can be limitations in specialized care. And a lot of times patients do present in, especially those from rural areas and underserved areas, they present late, and they're at a
Okay.
worse stage. So that can be potentially a reason why that can be a barrier to equitable access.
Yeah. That makes a lot of sense. A lot of these things are monthly pronged. There's not one simple answer,
Yeah.
which we
But we can
which
do
would make
things
should
to,
be have.
as a group, as a society, as oncology together, we can do some things to, I guess, work towards that in some ways.
Yeah, and I'd be curious, what do you think we could do, to make equitable access to immunotherapy?
I think it will involve a lot of policy changes, and we as clinicians have to work together as well. I think supporting navigation programs and having some financial support system, and maybe also expanding telemedicine for counseling and toxicity monitoring, such that people who live in remote areas and may not have access to, say, bigger centers, so they can be evaluated and looked at. And I guess improving insurance coverage policies as a whole would really be uh, beneficial for patients. I think just we require
Of
structural
course.
solutions, I guess, not just individual efforts.
It sounds like a big project with many different moving parts.
Yeah.
Yeah. Yeah. And with regards to quality of life, how can quality of life data guide treatment decisions? And what tools do you currently use for monitoring quality of life in your practice?
Quality of life, I guess, helps contextualize survival. So living longer, of course, is important, but how patients live matters just as much, is what I think. So if, say, two treatments have similar survival, but one preserves functions and reduces symptoms or minimizes treatment burden, that matters. And patients do care about fatigue and appetite and ability to work and daily functioning. So when all patients with cancer, the journey towards through cancer is not straightforward. They have this multiple symptoms, toxicities, and appointments, and a lot of burdens that come with it. So there are various tools that exist. There's like EORTCQLQC30, which is a European-based tools, which has 30 questions, and there's some tools which are directed towards specifically towards particular cancer. For instance, lung cancer has its own tool like QLQ LCT 13, which is a 13 questionnaire tool, or I think. So what I have noticed is the the bigger the tool, it is harder for patients to check this off. So if you have like 40, 50 questions to go through, it's really not possible to do that every visit. So the smaller the tool, the easier it is for the patients and also for the clinicians to kind of contextualize what's going on. So I think going forward, coming up with a tool which is limited, but also catches the information that we need, I think would be the way to go forward.
Yeah. And do you think like a paper-based tool or some sort of digital platform, or how do you do it with Present, and what would you like to see?
Right now, we just do it paper-based, but I would say with AI and all of those things coming in, I think if integrated EMR tools are present with the utilization of AI, that can really be make a world of a difference when they don't have to actually go through all of the check boxes and have a specific tool for their own need.
Of course. And I guess the million-dollar question at the moment is AI and oncology. So I'm curious your thoughts. What you think? What role do you think it will play? In advancing medicine and making care more accessible to everyone.
Yeah, like you said, AI is huge. I think it will probably deserve its own podcast at this point. Yeah. But if I had to pick one area, apart from the quality of life avenue that I mentioned earlier, I think the way it can transform workflow. So as you know, as clinicians and physicians, that there's a lot of note taking and documentation and all of those that kind of takes away a lot of your time. So the AI scribes and co-pilots and all of those, I think, really save an enormous amount of time. So instead of having to spend 2 hours after clinic trying to just finish your notes, you can utilize that time to actually talk to patients and then do teaching with your students or do work on something else. And it really helps you have a good balance. For oncologists, you do need, if you are giving so much of your own to the patients, you also need a time for yourself to be able to do that again the next day. So to have that time and not being burdened by just constantly documenting, I think that would really be a game changer. And as AI becomes more integrated in guidelines, support and triaging and all of those things, I think it's going to play an even bigger role in improving access to all patients.
Yeah, brilliant. And final question, what advice or wisdom would you offer to individuals considering a career in oncology?
I would say just go for it. This is an amazing field. You get to build long-term relationship with patients. You get to be a part of rapidly evolving specialty, and you are always learning. I think there's no better time than now. I think with ADCs and immunotherapy and targeted therapy and AI, it's the best time to be in oncology. So you just have to decide and go for it.
Brilliant. Great answer. Thanks very much. That was a very interesting conversation. I'm sure our audience enjoyed the conversation as much as I did. And thank you for everyone listening in, and we will see you on the next one. Cheers.
Thank you for having me, Kevin. This was a lot of fun.
You're very welcome.
Yeah.